Imagine 3 different scenarios. Number 1, you and your wife just had a child. You decide it's time to do your will. Some of the questions ask if you'd like to have things like CPR or life support machines if something happens to you. Of course you say, I'm young. Why wouldn't I want to do that? Scenario 2, you're sick, in hospital, but relatively stable. A physician comes up to you and says, if you get really sick and your heart stops, would you like us to do everything? You look at them with a mix of fear, surprise, and confusion. Am I dying and I don't know it? Why wouldn't I want everything? So much goes through your mind. Scenario 3. Your loved one with multiple medical issues is in the hospital quite sick. A doctor talks to you about the current situation and how if things get worse, invasive measures like CPR would just hurt them without helping. They don't recommend doing life support, and if the time came, to let your loved one die peacefully without those interventions. You're not sure what to think, but understand that it is time to truly consider this. The reality is, whether you're young or old, sick or not sick, or thinking about it at all, conversations around your wishes when you are critically ill are everywhere. These talks are fraught with tension, can shock you, but can truly be used to honor you or your loved one's wishes. Today on Not Another Medical Podcast, we'll talk about the code status discussion and what makes it one of the most difficult, but possibly rewarding, conversations you will ever have.
The views and opinions expressed in this podcast are those of the host and guests, do not reflect the official policies or positions of any affiliated institutions or organizations. This podcast is for informational, educational, and entertainment purposes only, and it is not intended to provide medical advice, diagnosis, or treatment. Listeners should consult their own health professionals for any medical concerns.
I'm James Jung, a general surgeon.
I'm Brodie Nolan. I'm an emergency doctor.
And I'm Josh Levitz. I'm an internal medicine physician, and this is Not Another Medical Podcast. And we're back.
Hey, boys.
How you guys been?
I think I stole that from something. Now that I said it, we might have just copyright infringed.
I think of Chance the Rapper, but I don't know. It's a tough phrase to trademark.
More the intonation.
That's hard to trace that.
Yeah.
Okay, good. We're safe.
Hey, so this is the first recording after we've published our episodes, right?
Mm-hmm.
I don't know if you guys had a chance to listen to our body of work.
Wait, us? Like, as in, like, Josh and I?
Well, I mean, like, collectively here.
Yeah.
I've certainly listened to our recording. Maybe
I think
twice or 3 times.
I think all 10 downloads are from me. And one from my dad.
Yeah. Yeah. Shout out to Dennis.
Dennis. We love Dennis. We don't know you, but we love you. Yeah. My mom said, it sounds like a good idea for a podcast, but I'm not interested. So, sorry, guys.
Yeah, I mean,
Just
I think
joking, Mom. She's listening.
That's a legitimate point.
We've all made a terrible
There
mistake.
are many things to do in this world.
Yeah. Well, we really appreciate the 5 people who listened and 1 person who commented. But I think it was and kudos to all of us for great job editing. Pre-edit and post-edit, huge difference.
Mm-hmm.
in
Yeah,
quality.
I don't know if anyone knows, but we are not well spoken. There's a lot of magic going on
It's a
behind the
mess.
scenes. Sorry, Josh, I see your face.
Yeah.
Let's be honest.
No, I'm with you. We're also amateur editors now.
Mm-hmm.
So
Yeah.
hopefully,
Yeah.
I mean, it sounds good to me.
Add that to the resume for skill set. Yeah.
I already have.
Yeah.
Amateur podcaster, amateur editor. We got a lot of amateurs in my resume.
Amateur producer.
I get. You know what? Yes, amateur grip.
There you go.
I
3
think it's
lines.
called.
Yeah.
There you go.
Yeah.
There you go. Oh, that's great.
Oh, what have we
what
done?
have you guys been up to? I know we had a little bit of hiatus.
Yeah, I was just telling Brodie, work has been bonkers. It's like winter time in the middle of the summer in terms of volumes. And for listeners at the hospital, winter gets busy because of all the viruses and stuff.
Infection.
And I don't know,
Yeah.
the summer is just, it's blown up. And my wife and kids were sick of me working so much, so they went up north for a few days. So I'm home
Good for
alone
them.
right now.
Nice.
Yeah,
Mhm.
They weren't actually sick. It was planned. They love me 80% of the time.
Is planned yesterday.
Yeah, exactly. But I was just saying to Brodie, it's like my house is quiet. It is the weirdest thing. It is nice. It is. I miss them. It is all of the above. It's
Right.
weird.
Yeah. I still get like a bit scared being in the house alone. Like if there's no one here, it's kind of like, and we've got like a super old house. Like there's no way anyone is like creeping in the house without me knowing. But there's still a degree of like, I don't know, Jules is gone, the girls are gone. It's like it's so
Yeah.
quiet.
You probably hear some creaking sound when there shouldn't be any creaking sound, right?
Yeah,
And that
exactly.
probably scares you.
Oh, that's just Ghost. She's fine.
You're more worried about the plumbing issues.
Yeah. Oh my God. We just had the
That's
back
scary.
again. I get to go a whole podcast on the challenges of plumbing in a 100-year-old
It's
house.
the pipes.
Why won't
Yeah.
you drain? Just drain. Who thought clay
yeah.
pipes and tree roots would be a good mix? Just saying.
You know what's durable? Clay. Not.
Yeah.
Mixes well with water. I hear it's perfect.
Totally. Yeah. Yeah. Like a Play-Doh consistency would be perfect.
Now we're clay pipe experts. James, what's up with you, man?
I was back home in Canada. I mean, although not in my hometown of Toronto, but
Oh, yeah,
Calgary,
right.
Alberta. It was really nice.
Shout
was
out
good
to
to
Calgary.
escape. Yeah, shout out to Calgary. It was good to escape the heat for a bit. Nice and cool. Beautiful mountains, beautiful lakes. You know, it's just an amazing place. Really
Yeah.
loved Banff and, you know, Lake Louise and all of it. It's just beautiful.
Yeah. Winter skiing is just incredible there. Summer is beautiful. You know,
Yeah.
I'm a Canadian, so the winter sports take it all.
Oh, yeah.
If we're keeping tabs, though, I think this is like 9 of 10 episodes that James has gone somewhere since we recorded last.
Wow.
And I have a lot of trips coming up actually in the second half of the year. So there'll be a lot of me dropping
half
my
medical
my
and half
geotags,
James's travel journey. That's it.
my geotag locations.
Oh, that's awesome. Good for you. You should travel.
Yeah, thanks.
Yeah.
Yeah, maybe we should do a travel show.
No. I'm just gonna say no.
Just no.
I think that's like the last. You're not in improv. You're always supposed to say yes, but I'm just gonna shut this down.
Mm-hmm. Yeah, that'd be a
Fair
very
enough.
tough sell.
I wasn't sure where I was going to go with that either. So good call, Josh.
Yes. My improv class did not pay off.
I thought you were supposed to say, and yes. And
Exactly. Yeah. Like this is.
yeah,
But I said no.
it's opposite
so
of what you learned.
Don't constrain me.
Yeah. So speaking of staying home, so you guys may or may not remember, but Julia, my wife, really likes reality TV shows.
The animal dead guy? No, sorry.
Yeah. Yeah. and hot animal guy. So she'd been watching Love Island recently, specifically Love Island USA. And my oldest daughter will often decide she doesn't want to sleep anymore and come down into the basement and then just kind of watch episodes of whatever happens to be on TV. So Advance a few days ago, and my daughter comes into the room and just like, you know, kind of gives like a morning cuddle like she often does. And then goes in to give me a kiss, and all of a sudden there is an aggressive tongue in my mouth, and I was like, "Oh God,
Oh no.
what is happening?" And
Yep.
I was like, "Okay, like play it cool." I was like, okay." And then I'm chatting with Jules later, like, I think we got to like rein in the Love Island watching. Like, I think she's picking up some stuff that she probably wouldn't have picked up otherwise. And she was like, no, it's totally fine. And then sure enough, like that afternoon, the
not
same
fine.
thing happened to her. So,
And she said,
and so
Wow.
we're now limiting any sort of Love Island watching with her daughter around. But
Well,
quite funny.
wow.
Pro tips. Pro tips for parenting.
Yeah. I don't want to make any jokes just because there's a lot of dicey area here.
It was pretty funny.
Ugh.
We're all going to be okay.
Yeah.
Yeah.
I think, you know, kids forget quickly, hopefully.
I won't, no.
Brodie.
Anyways, that's my
won't.
awkward segue for the day. Back to you, James.
Yeah. Yeah. It's hard to make any jokes because, you know, it's our beloved niece.
Yeah, really.
Oh, man.
Well,
okay.
I don't think
Well-
I don't think we're topping that, so we might as well just get into
Yeah.
it.
Well, speaking of awkward conversations that you could have with others,
Nice.
here we go.
Nailed
Here
it.
we go, right?
Mhm.
Just for the record, because I think we've talked about segues like 100 times. You're not supposed to call out the segue every time, but we're going to call out the segue every time.
Yeah, and I think
Yeah.
that we should be calling a segue out every time.
100%.
That's how you
That
know
was
it's
an awesome
coming.
one.
Absolutely.
Yeah.
Absolutely.
Yeah.
It's the only way people would know.
Yeah.
We have to really highlight how funny we are because otherwise we're just not funny.
Right.
What's
Yes.
that, listeners? You actually want to hear a medical podcast and stop
Damn it.
talking, guys? Okay, let's go. Yeah. So, guys, we're going to talk the code discussion. Dun dun dun.
And this is not cracking
Okay.
the code like a cool wartime code machine.
No, but there's cracking the code conversation might actually be a good title for this. Yeah.
You're welcome.
Yeah.
Are you done yet?
We're both finished. Thank you, James.
So let's talk about this code discussion. Even from the title of this, like, I don't know if the listeners really understand, or maybe if they have been involved in this discussion, they'll understand it, because once you have something like this, you'll never forget it. But for those who have not had opportunities to participate in this, Josh, tell us like what code status means here, and what the discussion around that code status entails.
Yeah. And I think you said it. There's a bunch of listeners, well, however many listeners there are, there's a bunch of those ones that are like, oh yeah, I know what's going on here. There's a couple that'll just no clue. And this is something most people will probably be exposed to. So a code discussion is really something that a healthcare professional will have with you, not necessarily just healthcare professional, but we'll focus on that. And it's a decision around critical illness and what happens during times of critical illness. It's an absolutely vital conversation to have, and especially more so in different settings, and we'll get into all that, but it's not something that people actually do like to talk about, because at the end of the day, you're talking about life and death with these conversations. And just to be very specific, what we are going to talk about during this podcast and what the code conversation is what kinds of things do you or your loved one want when you're critically ill? And we're going to talk about things like CPR, where we press on the chest. Everyone's seen that, or most people have seen that in TV or movies, or hopefully not in real life. Intubation, where we put tubes in the lungs to get to help people breathe on machines, and some other life-saving treatments. So it all sounds very complicated because it is. And I think we'll just kind of flesh out what the code conversation is, why we have it, why it's difficult, lots of things to go over with this.
So maybe let's break it down. There are, at least in my mind, there are kind of three options is probably not the best word, but there are kind of 3 or 4 different status within this code discussion. Can you tell us like what they are? Let's start by saying that doctors, a lot of doctors, not everyone, like not all of doctors, but doctors are not good at talking about this either, right? So sometimes you'll hear, especially from more junior trainees, if they are having this conversation, like they'll just kind of blurt out all these different, like DNR, like CPR, like DNI, like, what do they mean? And tell us like, what the listener should understand.
For sure. So you're getting Josh's view here. And I'll just be very specific about that, because everyone has a different view of what is a good code conversation, what these things are. The whole option thing is a very interesting conversation. I try to stay away from options because this is a continuum of what people think is best for them during their critical illness.
Mm-hmm.
So things we will talk about, and just specifically, I said a couple of them. So CPR is a big part of this conversation. If your heart stops, here's what CPR is. Here's what it'll do. Is that something you want to include? Number 2, life support machines. And again, we talk about the breathing machines, so putting tubes in your throat. So intubation, if you hear DNI, that's do not intubate. And then there are simple things, not simple, but easier things like intensive care unit care, where you're on special medications to keep you alive if this and this happens. And as much as like this all sounds like, of course I'd want intensive care unit, these things carry a lot of side effects and complications with them. And it's not a simple yes or no. And we'll get into that in a bit. The big one people hear, and this may kind of clue people in, is DNR. It is my least favorite 3 letters. DNR means do not resuscitate. But if I poll 1,000 people about what resuscitate means, I'm going to get 1,000 different answers. And if I just ask you guys, like if someone tells you DNR, what does it mean to you? Or what do you kind of talk to patients about when you say DNR?
Yeah, I think that the DNR is often attributed with, unfortunately, not doing anything, which is not really what it is, right? Like when I think of resuscitation, really these are the invasive things that you're talking about. For the most part, it's supporting someone's breathing through a breathing tube and or chest compressions if the heart stops. So for me, DNR means that someone's not going to have chest compressions if they lose a pulse. And if they get into worsening problems with their breathing, we're not going to go to the point of inserting a breathing tube. But between those, there's a lot of other, escalations in care that can still happen, right? You can get support through things like BiPAP or CPAP. So again, people at home that might have sleep apnea might have like a CPAP machine that helps you their breathing. In the hospital, we have things like that as well that can help with people that have some breathing difficulties. So again, Josh, it kind of like you said, it's not really an all or nothing. And I don't think the checklist kind of menu type approach is helpful either, because I don't think that it's actually really fair to people to understand what these things are. But when I think you're talking about code status, what's your underlying goal of that? What's the purpose for having those conversations?
Yeah. So I see it the same as any medical intervention that we do. You start a medication, your doctor is going to talk to you about risks and benefits. You're going for surgery with James, he'll talk to you about risks and benefits. You're seeing Brodie in the emergency room. If you're awake and alert, he'll talk to you about risks and benefits of seeing his beautiful face beside you.
And if you're not, I'll whisper them into your ear.
Yes. There you go. And I've seen him do it, guys. The same thing here. These are interventions. And you need to know what can happen and what it will do and the side effects and the benefits so you can make a personal decision. So it's patient autonomy at the end of the day and shared decision making, where you have the right to decide how things go for you. Now, I think there are situations where these kinds of things are not going to be offered, and maybe we'll get into that later. So it's not always your decision, but at least just inform you on what is available, just like any other medical intervention. Does that sound?
Yeah, I mean,
Kind of what you guys think? Yeah.
Yeah, the interventions that Josh are talking about, these CPR or aggressive or invasive resuscitation, these are taking place in case of somebody having, crisis, right? We're not doing these interventions on patients who are doing fine. These are patients who are having cardiac arrest or respiratory arrest, or this is when their heart stops moving or they're not breathing, they're unconscious. And that's when we have to act very quickly in order to be able to revive these patients, bring them back to life, literally. And if we don't have these discussions about what interventions the patient would want in advance, we're just not going to have the luxury of the opportunity to talk about that at the time of crisis. So when patients are admitted to the hospital, especially where we think that there is possibility that this patient may face unexpected crisis, it is important to have these discussions earlier on so that the patient's wishes are reflected in how the care is provided at the time of crisis. There are patients who would say, I've lived pretty good 92 years of my life. I know that I'm here because I have pneumonia, and there is a chance that my heart may stop. If that's the case, then I don't want some provider compressing on my chest, breaking on my ribs, and the expected percentage of me surviving that is very low. I want to pass away with dignity and without having all these things happen to me. So I think this is the discussions that we're talking about. this is why that advanced planning is important.
Yeah, James, I think you nailed it there, right? It's really trying to respect the patient's values for what they do and don't want being done to them as well, right? At the end of the day, these are all interventions. These are all treatments to which we would try to ideally have those conversations ahead of time. I will add on that there's also sometimes, anticipated deaths as well. So thinking about patients that maybe have advanced stages of cancer and, part of palliation and I think kind of your goals of care comes up into play for some of those as well. So I totally agree. I think ideally, these talks could be removed from an emergency or, really timely environment, because those are really challenging times to try to have those conversations when they're really pressured and you're not able to have that. And you're not sure, because I guess otherwise, if we don't have any, goals of care, then really it's the healthcare providers or the family that kind of takes on that burden of trying to guess, what would the patient want and what would their values be. So it's great if you can have those ahead of time.
Just to summarize, you want to have these conversations when you don't need to have these conversations. So, in a perfect world, if family doctors had more time and less patients waiting in the waiting room, a lot of them would probably have this discussion. And this discussion changes. If you're a 30-year-old and someone says, hey, if this and this happens, we can do CPR and intubation and you're otherwise healthy, the survival rates are decent in those cases, like 20, 25%. So you're going to say, yeah, do that. If, like you said, James, you're 90 and you have other medical issues, you're often going to say, no, don't give me these traumatic interventions. But some people, they may say, you know what, I want to live as long as possible, no matter what. So do that.
Yeah.
But the earlier you have the conversations, the better. And it is just fluid. So always thinking about it, always changing it. And as importantly, just Brodie, you said it already, you need to know what your loved ones want. So you are not struggling to make the decision when they're sick, because the emotional toll that takes and the inability to take emotions out of those kinds of decisions makes it so difficult if you're deciding for someone else.
There's some staggering statistics around, this. Unfortunately, these discussions do not take place in advance and are not documented anywhere. Some studies demonstrated that like 40% of patients who are in critical conditions do not have any code discussion documented. So this really, makes it challenging for providers to understand what the patient's wishes are at the time of the crisis. And at those points, you're kind of giving up your kind of right to choose how you want interventions to be provided to you. The other thing is that oftentimes, even if these are documented and you as a patient have had discussions with the providers and these are documented, the families may not remember or understand what the discussions were. And some of the statistics around that is that, about 30% of the families, don't remember having had these discussions with the patients. And because of that, they're in very high emotional distress when, let's say, the loved one had said that, I do not want any resuscitation, and the patient is in crisis, and the doctors tell the family, well, we're not going to perform any CPR or heroic measures, and the family feel very much distressed in these kind of situations. So,
James, I am gonna the word heroic. I can't keep quiet. Oh no, I jumped in.
Well, I stand by those. I think it's really a heroic. Not that what we're doing is heroic, but it is really, you're throwing everything. It's a Hail Mary. If you're going to use sports analogy.
Hail Mary, I'll give you. This is a really good thing. This highlights the difficulty with these conversations that maybe we'll get into is everyone has different wording. Everyone has different ways of doing it. And to do it right, you need time, you need space, you need quiet. And really to do it right, you need multiple conversations for people who just have never gone through it all before. But we do have all these words like heroic. We have phrases like, do you want us to do everything possible? And depending how those are put out there, it can really sway someone's decision,
Yeah.
even if it's not necessarily what they want. It's very interesting because when you hear heroic, you're like, yes, be a hero.
But Josh, to your point, I think it's and I've seen this and been involved in some of these conversations that the terms used can very much so change the tone of the conversation or things like that as well. And it's interesting. So I'd say of the three of us, you probably have the most goals of care discussions. Certainly in the merge, when I have to have them, it's awful because it's loud and chaotic and in the middle of the hallway, and it is not an ideal place to have them.
And you have to make the decision. When
and then you're also
Brodie. You're
forced at a
doing
time
it 'cause
where,
yeah.
absolutely, yeah. So, Josh, maybe share okay, you're prepping to meet with a family to talk about code status. Like, what do you do? What's your, what's the approach? What sort of things? Like, how do you phrase it for families?
Yeah. So first I figure out if they've ever had the conversation before. And if like a med student was in the room before me and I know they just had the conversation, I know I may have to walk some things back.
Jay walked out saying, I'm a hero.
Yeah.
I'm going to do it all.
Exactly. Yeah. Generally, I'll walk in. I will talk to the family about other things first. I don't usually walk in and say, hey, I'm Josh. Do you want CPR? I'll figure out where things are at. And I will tell you, I have these conversations with someone coming in with a cough. They're completely well. And I have these conversations with people who are like borderline going to the intensive care unit. So I'll build a little rapport. And then I'll set them up. I'll say, hey guys, like I got to talk to you about a pretty hard subject that you may or may not have heard before. And I say, have you guys ever talked about things like CPR, life support, intensive care, or have the word DNR come up in your life? And I will ask them and let them kind of tell me. Most people, I will say these days, who come into the hospital have heard it in some way. And I mean, I'll kind of say, hey, has there been decisions made before? If it's a yes or no, then conversation is done. If they have it written down somewhere, even better. We know what everyone wants. But then I'll go into the specifics and I'll talk about CPR and I'll talk about how it can save a life. It can keep a heart going, but it doesn't often fix the underlying issue. It can break ribs. It's very traumatic. And depending where you are in your age and medical journey, the chances of survival are 0% all the way up to, 25, 30%. I won't throw percentages in there too much. Then I'll talk about life support machines. If you go on that, there's a lot of medications, there's trauma to the airways potentially. And depending how sick you are and what you have, coming off those machines might be really, really hard. And you might not ever be able to come off. Again, someone who's younger and healthier, I'm not going to phrase it that way necessarily. So I will be gauging my audience and I will be using my experience to say, this probably is a good idea for you because it may work if that's what you wanted. Or in some people these days, I'm so comfortable saying, don't do this. It is not going to work. Just like if you don't have diabetes, I'm not giving you insulin. If you are 90 with cancer all over your body, do not do CPR or life support because it's not fixing the cancer, which is ultimately leading to all that. So more in those conversations, but like I kind of gauge it to the person. That's my style. I am one out of a billion doctors. So
I didn't know that there are a billion doctors out of this world that only has 11 billion or something like that.
James, you're not the only stats guy here. Okay, I could do stats
check
too.
that for sure, James.
I think it's something
Pulling it
about
up
10%
now.
of the population.
Josh lied.
Anyways, but it's really hard discussion, and as Josh alluded to, I think Josh, you definitely have a broader and deeper experience with this. In surgery, the discussions are a little different because it's more episodic in that I'm treating the patients, taking this patient to the operating room, and they're usually they receive general anesthesia, meaning they're intubated already. I don't know whether I agree with this ethos or not, but because we're so much into the invasive therapy, we feel that we would do everything in case of, cardiac arrest or heart stopping or breathing stopping to get them back at this episode of perioperative period. Although, I feel, their chances of survival are probably unchanged, whether it's surgical or not, right? But we feel that, if it had something to do with surgery, then the onus is upon not just the patient's disease, but the surgical outcomes that we need to try to reverse if it's due to the complications of surgery, that we feel that we should do everything possible to get them better. So there's some variations of, this, but general kind of consensus among surgeons is that we're more aggressive because we're taking the patients to, very invasive therapies, that we would do everything to bring them back, even at the extremes of critical conditions.
I'd argue if you're in there in surgery, you're trying to fix something. And if something big and bad happens, like the heart stops, lung stops, you're in there trying to fix what's causing it. So maybe with that conversation, it is a bit more realistic that you do those things in people who may have said in other situations, I don't want it.
Well, but also
Maybe.
It carries over to, after surgery for the period of time that they're recovering from surgery too. So, but because, we feel that, what happens in the surgery likely is the determinant of their outcomes. So we feel that we should go back to the operating room and try to fix it if it's caused by surgical issues.
Yeah. And it makes sense too. I mean, to a degree, I can see code status being sometimes fluid when it comes to you going for surgery, right? Because there are inherent risks just to the anesthesia, the medications that might drop your blood pressure, be really low, and you just need a brief period of some additional medications or some support or something like that to get through it. Whereas it's a very different than if you were to, your heart were to stop for other reasons. So that totally makes sense. Josh, and James, actually for both of you, I'm quite jealous for the time you sometimes potentially are able to leverage for being able to have those conversations. I think, again, in the Emerge, it can be very short. Yeah. The most drastic example that I have of this is, I remember one time with a very sick patient in front of me, family was at bedside. And, maybe for listeners, it's really hard to know when someone's going to die, right? And sometimes I get an idea that someone's probably going to die, but I don't know when, minutes, hours, days. That could be really, really hard to tell. I knew the patient was really sick. I knew they needed to come into the hospital and they didn't have anything for a goals of care discussion. And I remember literally as I'm doing the introduction to try to not be, as Josh joked about, like, hi, I'm Brodie. Have you ever thought about CPR? As I'm starting that introduction, I see like the heart rate on the monitor going down and the blood pressure going down. And like the speed of my voice had to go faster and faster to be like, I have 1 minute to get an answer.
And listeners, when Brodie gets excited, his voice goes high and it goes fast. It is impressive. We will get it out on one of these podcast episodes.
Yeah, this is me like 3 times speed slowed down when I'm on here. Like it's, oh man, but I remember that happening, being like, this can't be real. But it can be really pressured. So I think to add my take on that then is I tend to err on the side of maybe being more on the aggressive edge because it's easier to scale that back afterwards, right? So if I'm not sure what someone's code status is, we don't have the luxury of having that time, then it might go towards the end of doing, quote unquote everything, or starting CPR, intubating them. And sometimes that unfortunately comes out that actually they did have a code status that wasn't part of the patient's wishes. And like, that's a really hard thing for the team that happens. But it's usually in the context of we're dealing with the best information we have at the time and trying to make those decisions literally sometimes with like seconds or minutes to try to make them.
And, for patients and their families who are listening to this conversation, they may feel very puzzled too, right? Like, let's say their father or their loved one is getting admitted to the hospital for pneumonia. He's had pneumonia before and he survived that fine without any issues. Why are we all of a sudden having these conversations about whether he should have CPR or not? So they may feel very puzzled. And I think it reflects that the inconsistency in us, right? Like not all doctors do a good job of just documenting the code discussion or having discussions about code. feel uncomfortable sometimes about having discussions about code status. So I could certainly understand why patients feel puzzled when they're approached and talk about it. What are your strategies to in talking to patients who are too overwhelmed to make a decision right away?
I mean, it's a nice distraction for not talking about politics over Thanksgiving dinner. Let's just hammer this out, fam. We're gonna sit down. Who wants CPR? Who wants a breathing tube?
Yeah. I'll take a drumstick and some CPR, please. Yeah. It's amazing. Like I consider myself decent or good at these conversations. Over the years I've developed it. More than an amateur in these, I would say. But once a shift, I will scare the hell out of someone with this conversation unintentionally. Like I will walk in, we'll be having a great conversation. I'll say, hey, we got to talk about this, and this. And they'll look at me and say, why didn't you tell me he's dying? Or why are you doing this? And it is just, I'm like, this is medical care. I got to do it. And I've had patients yell at me. Like it's just inevitable because the emotions are high. Strategy is you don't have to get an answer most of the time in that moment. You are there to start a conversation outside of the urgent ones like Brodie's talking about. And you give them time and you say, listen, I don't need decisions now. I mean, the person whose body it is should be able to make the decision, but if they can't because they're unconscious or otherwise, and you give them time and you say, I'm going to circle back with you, talk to your family. Let's just take it easy. Inevitably, it's a tough conversation. People don't like talking about death. And let's be honest, that's what we're talking about, how we die or how we live. It's uncomfortable, but it's so vastly important.
Yeah. The other way to frame it is, though, it's also kind of helping you choose a bit for what that death looks like. And I know we're not talking about like medically assisted suicide and MAID and those types of things, but there's a degree of, you know, when you're approaching something so critical like that, like what do you want that to look like? So it really is trying to empower patients to make sure that everything is done for their wishes. It's almost like the way that we do screening for colon cancer, your tetanus shot is up to date. It's almost like there should be a recurring part within the primary care system, ideally, where it's just a routine part of your check-in, you know? Like, I mean, I think about, we have like a financial risk tolerance, right? Like you meet with your financial advisor, if anyone has one, and they're like, hey, when do you want to retire? What's your risk tolerance for investments? And they do that every time because they have to by law to be able to do things like that. It's almost like the same. It's kind of what we should be doing. Like, what's your tolerance? What's your code status? What would you want done if these were the things? It's going to change over time.
My financial advisor says I can never retire. Is that good or bad?
He said to start a podcast.
He said, don't focus on something that will make you money.
James and I have been your financial advisor for the last 3 years.
That's right.
It's so true. Everything I've learned.
We took over.
Oh boy.
Here's another scenario that I've come across, especially when the patient is elderly person, and then there's usually a dominant family member, whether that be their child or children, or, you know, a spouse and whoever, right? And they like to be at the center of the discussion. And they're doing that not because they want to, but maybe they want to, but they're doing it in the name of, I want to protect my mom or I want to protect my dad from this emotional discussion. They can't take this kind of discussions. How do you approach, you know, you guys, I'm sure you guys have come across this. You know, how do you approach this kind of scenario?
Yeah. Like I see more often with the breaking bad news kind of thing. Like I'm telling someone they have cancer, but the family's like, don't tell them. And that's maybe a discussion for a different time. These ones, if the person is awake and alert and capable, I say to the family member, I appreciate your input. I got to hear from Mrs. X. This is her decision. She needs to be part of this, unless she defers to you. And I'm pretty honest about these things because these decisions should not be made by someone else if you are able to make it, or unless you want someone else to make it. That's me.
And I also see, you know, the same patients, you know, these patients who are elderly, you know, usually they feel a little, to some degree, guilty about being unwell, sick to their family, right?
Mhm.
You know, sometimes their family members are supporting them. And, you know, I hear from patients like, oh, I feel bad that my son is taking me to the hospital all the time and I'm taking too much of his time. And when conversations about this life and death situations comes along, they inevitably kind of looks to the family members and kind of shrug and say, oh, like, I don't know, it's up to, you know, my family members, or it's up to my son, or, you know, whatever. You know, it's heartbreaking to see.
Maybe to kind of summarize, I think what you're getting to, James, it can be contentious within. Sometimes it can bring up family dynamics. Sometimes it can bring out dynamics between the providers and the family as well. And so I think it is good sometimes if if you are a family member who's questions to ask questions. And sometimes if I'm the provider and I feel like it's kind of steering into a way that it's, you know, getting people's back up against the wall, maybe they're getting a little bit distraught. If you have the time, then taking Josh's approach of, you know, I want to plant this seed. I want to come back and talk about this. Let's set a time to come back where we can discuss something, I think is a really good approach. And then trying to bring other people there. And even sometimes it's clarifying that the right people are there for those meetings too. So it kind of sucks that it leaves sometimes like a bitter taste, you know what I mean? Or memory for the family for that. So I do think, you know, calling upon additional people within the healthcare team from there, making sure that the family is supported as best they can to try to have someone there that they feel supported with and represented with.
Yeah.
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 And I think two good things on that. Number one, if the family hears it, they've heard it. So they can't argue it later. If something happens to the person making the decision, that's always important, because inevitably, if there's more than one child in a family, they don't always agree. So if you hear it from the source,
that's the other thing. Yeah.
And then I think number two, with what you said, Brodie, going back to this DNR, do not resuscitate. It's a tough conversation. You're talking about end of life, but if you don't use this resuscitate thing, you say, like, here's the things we can do. It doesn't take away all the other stuff we're going to do, though. Like, we're still going to give the antibiotics and the fluids and the other medications if that's what you want. So it's really important that, even though it can be a tough conversation about end of life, you have to be clear that some people would say, are you just giving up on me? And you make it clear that unless you wanted that kind of end of life care, which is a whole different thing, we're still treating you. We're just not treating you with stuff that may or may not help you.
It's not just the life sustaining measures like that we're not providing, right?
Yeah.
So, it's a great distinction to make.
Yeah. Brodie, we'll still whisper in your ear if that's what you want.
I'll still whisper all the things to make sure. Yeah, squeeze my hand if you understand. No, but I think, James, it's such a perfect distinction, and it's what we talked about initially, right? DNR does not mean do not treat. And so I think the other thing when you're having these conversations is, especially if it is going to be like an end of care thing, is to talk a little bit about palliative care or end of life care, right? So if, you know, things we're not going to do, we don't want to do chest compressions because it's going to break a bunch of ribs. It's going to actually cause pain. That's going to impair the ability to, you know, to come back. It may not do anything. It may not solve your underlying issue that you're there for, like Josh was saying. And again, with putting a breathing tube, again, it's very uncomfortable to have a breathing tube. Being on a breathing machine, some people go on, they may not come off. But, you know, if those things are okay, you know, what can you, or what are you going to do? If you're not going to resuscitate, what are you going to do? And that's where then it's, you know, what is comfort care, right? We're going to make sure they're not in pain. We're going to make sure that they're comfortable. We're going to make sure that they're hydrated, like that we're treating infections. Like those are the things that you are doing, right? I think sometimes that's the importance as well. So family doesn't feel like it's this, oh, they're DNR, they're gonna, you know, leave us in the hallway and no one's gonna treat us, right? I think that's really the concern, right? But if you ensure that they're not going to have any pain, we're going to keep them comfortable. We're going to, you know, treat the things that we can treat without those. That's, you know, hopefully some degree of reassurance.
Canadian healthcare system, you'll probably still be left in the hallway, but you'll get treatment while you're there. Just got to clarify that one.
Thank you for that clarification. I want to, you know, there's something that I've been kind of thinking about that I wish the listeners will hear this as well. Talking about how your end of life will look like. increasingly more and more, when you're in a hospital setting, when your heart stops, and we'll see that, when your breathing stops, we'll see that because we have monitoring going on. If your status is full code, meaning you want chest compression, intubation, in the United States especially, because the healthcare providers don't have the ability to reverse the course of, the status code. Unlike Canada, there's some not flexibility, but there's some degree of, making medical decisions.
We have the ability to say we are not doing CPR. We will not intubate if we don't think it's medically indicated. Yeah.
Right. But in the U.S. system, it's unlikely that the doctors will go against what's being documented clearly as full code. So if you foresee that your last minutes of your life will be that you're in a code situation with, 10, 20 people, not, loved ones, but healthcare workers, working on you, giving chest compressions, intubations, because again, depending on what age you are, what medical condition you are, and what kind of disease that brought you here, the chance of survival is exceedingly rare, right, in these situations. So if you have to think about how your last moments will be like, and how your family members will see the last moments for you as well. So these are kind of things that very, obviously emotional to think about, but I think it's really important for you, the listeners, to think about, and for all of us as well, as we get older, especially Josh. Gotta throw that in there.
I'm okay with that. I will bring it back. So a lot of what we focused on is these conversations in people who are sicker or who are maybe advanced age. And the reason we're kind of focused on that is that's where the conversations are the hardest. Those are the ones that we don't know if there's going to be benefit to these kinds of things. If you are my super young age, my super young age, Josh's super young age, you guys got this? And you asked me if I want intubation and CPR, I'm going to say yes. And I have a good chance of surviving.
Yeah.
Depending what obviously causes it. So we're not focusing as much on these, but I have had that conversation with my wife right now, and she knows if I ever get something that is terminal, or if I ever get dementia, that goes out the window. I don't want the intubation. I don't want the CPR. So again, it just kind of goes back to have the conversation. Yeah. Like Brodie said, all walks of life, all stages of life, you keep these things going.
Yeah. And it's longitudinal discussion. Yeah.
It's a good point. Trauma and injury can happen so quickly sometimes, right? And totally life altering things as well. And it does take some of that burden off your family, right? Which no one would want to burden their family with having to make the decision on their own. So I totally agree that, I don't know if we're in takeaway mode or not yet.
Every time I try to do takeaway, James interrupts me and tells me it's not time yet. So I'm not making this decision today.
Just don't let him talk.
Can I mute him?
So the way I'm envisioning, I go into my rabbit hole and take away 10 minutes.
All right.
My takeaway is that I take away 10 minutes of your time.
Yeah. Keeps going. Never ends.
So, final thoughts.
Okay.
But should I go?
No, Brodie has this. He started it. Go, Brodie.
Take it away. All right. My takeaway from this, have the conversation early, and it's going to change over time. But have it early. Let the people that you love know. Again, it's great to have these conversations ahead of time and not when you're in a moment of crisis. James.
So the way so I think, really, in all seriousness, I think my key takeaway is what I said, for the last 10 minutes, is that this is discussion about how your last minutes, of your life to look like. So be empowered and think about this longitudinally, and make the decisions for yourself. That was short, right?
I like that. That was good. I'm proud of you. And I think I'll finish off with saying, again, this isn't a one size fits all. There's lots of discussions to have around these medical interventions. And one thing that didn't come up, and maybe we'll end with, is when a doctor has these conversations, most of us should not be trying to get a decision that we think is right or wrong. We should be exploring values of the person making the decision. We should be medically recommended what we think based on the person and the medical conditions and all that. But this is your decision for the most part, and you should make it. So have those conversations, and thanks for listening to a pretty heavy conversation, guys.
Mm-hmm.
Important.
But very.
What'd you say, Brodie?
I said that was killer.
Nope.
But
That one's getting edited out.
Brodie, you killed it.
All right, boys. I know. Cause of death of
Brodie.
this episode?
This guy. I don't know.
All right. Well, Josh, thank you for that. Super important.
Yeah.
Heavy topic. But
yeah, I thought it was a thoughtful discussion, especially by me.
And let's end on that note. Guys.
Heroic
Take care,
James.
everybody.
All right, take care.
All right, guys.
See you next week.
See you next week.